Well, good afternoon and good evening, CNY Nation. I'm Dr. Randy Fink, the clinical director of IVF services here at CNY Fertility in Colorado Springs. Very happy to have you with us today. Hopefully, somebody is with us today. It's a little bit after 4 p.m. Mountain Time here in the beautiful state of Colorado. We got a little snow this morning. It wasn't too bad, but enough to slip and slide around on the roads just a little bit. But welcome to our first our first edition of Fertility with Fink and Friends. And what I mean by that is that we are here to talk about all things fertility as it pertains to you and your life, as well as questions about women's health, things that are on your mind. If you have questions, please feel free to post a question right here for me. We will have that and do our best to answer all your questions. We'll be with you today for, let's say 30 to 45 minutes. We'll see how our response is today. And then we'll be back weekly on Tuesday afternoons at the same time. Again, so happy to have you here. We have had a few questions from some of our patients who are not able to watch us this afternoon. And the first question was, well, what exactly is an endometrial polyp and how does that pertain to fertility? The endometrium is, of course, the lining of the uterine cavity. And I describe an endometrial polyp as almost like a little patch of weeds. A polyp is a finger-like growth of tissue that sticks up either like a tree trunk or hangs down like an icicle. That polyp or patch of weeds can occupy very valuable real estate that an embryo would otherwise like and be able to use for implanting. If you think about a polyp inside the uterine cavity, it may brush back and forth and potentially can act kind of like a windshield wiper, bat a good embryo right out of the uterus. More likely, though, it's taking up useful space and is the sign of a potentially sick endometrium. So a polyp is something that we definitely want to take care of. We recommend that folks have their endometrial cavities evaluated at least once a year. So depending on where you are in your part of the process, the endometrium is evaluated by doing one of two things. Either by doing a saline sonogram, and the saline sonogram is where we place the little straw inside the uterine cavity and place a teaspoon of fluid on the inside while we are doing a vaginal ultrasound. In so doing, we're able to see what's on the inside of the uterine cavity, and it can tell us that there's no polyp, that there's no fibroid, that there's nothing that we would call an endometrial filling defect, something that's in the cavity that can result in a beautiful, perfect embryo not being able to implant. The second way we would evaluate that is with a hysteroscopy. The hysteroscopy has to be done by a gynecologist. So sometimes it's easier for folks, depending on where they are, to have a saline sonogram done because it can be done from any imaging facility, whether it be the hospital, whether it be another fertility practice, or even your own doctor's office, whereas the hysteroscopy has to be performed by a gynecologic surgeon. Now, it can be done in the office. It's not something that requires anesthesia, but it's crampy. It's not comfortable. It really, for a diagnostics purpose, can take just 30, 45 seconds. It's not a big procedure, but once a year, we do recommend that folks have their endometrium evaluated. It's very common that Brandis and I here in Colorado will see our patients who have maybe been trying transfers for a while. And we talked to them on the phone because there's a question about why things haven't been working. And first thing we look at is when was the endometrium last evaluated? And sometimes it was 2-3 years ago. And so that's when we often find that, wow, there is something, some scar tissue, a band of muscle, a polyp, something inside the uterine cavity. And that is worth knowing. So once a year, please think about getting the endometrium evaluated. And if you're during the process, if you're at the beginning of your process now, It's a good time to take care of that and make sure that you have that done before you start to do a transfer. Hi, Samantha. We're glad to have you here. Samantha has asked us a question, and let's see. There we go. I'm confused about my egg quality. They were considered poor quality, but they fertilized and they resulted in good and fair embryos. Does egg quality at that point affect if the embryos are good? Does egg quality matter at that point if the embryos are good? And the answer to that is no. It really doesn't matter so much. And in fact, many embryologists would tell us that we shouldn't even think about grading eggs per se. And Samantha, you bring up a very good point as it pertains to grading, because grading is one of the most commonly misunderstood things that we deal with here. One of the most common questions that we face, well, what about my grade? What grade was my embryo? I want the best graded embryo. And I see on some of the social media that people talk about, what grade was your embryo? Well, the truth of the matter there is that most, if not all of us, went to high school. Certainly all of us did schooling at some point. And so we're accustomed to this idea of grading. Grading in school means that you are being evaluated relative to the rest of the class. And so I always say, okay, well, you got an A in English, which means that you studied and you probably did better than most of the people in the class. But you got a C in PE, so you really weren't as much of a jock as you thought you were. And so that puts us where we are relative to everybody else in the class. But embryo grading means something different. It's really not intended to evaluate how good one embryo is relative to another. Embryo grading was originally described to be able to determine which embryo might be normal and which one might be more likely to get you a baby. What embryo grading actually is when the embryologist describes a series of features of what they see under the microscope. But we really say that embryo grading is like a beauty contest. It doesn't correlate with the outcomes for fertility. So, for example, you could have an absolutely beautiful embryo, a very highly graded embryo that turns out to be have complex chromosomal abnormalities when you do PGT testing on that embryo, whereas you may have a very ugly embryo or a poorly graded embryo that turns out to be the only normal embryo in the bunch. So we encourage people not to pay too much attention to embryo grading. It's something that people throw back and forth and use it kind of as something that it's not intended to, and that's to say which embryo is better. It's not which embryo is better. That's really only describing which embryo is better looking, not which one is more likely to be normal. Hey, Sarah, glad to have you here, and we're excited to see you in Colorado come January. I hope you'll bring your winter coat. Actually, here in Colorado Springs, the weather is not so bad. People say, oh, Colorado. Well, I came here to Colorado for our IVF services from South Florida. So it's definitely been a change of scenery for me. But we moved here about a year and a half ago, or a little bit more than that, in April of last year. And while I got to miss all the hurricanes, we get a little snow. We actually have 4 seasons, and Colorado Springs is a very pleasant place to be. Melissa, glad to have you here, and we're excited to see you next week and hoping for good things really for everybody. So awesome, and happy holidays to all of you. It's about 10 after the hour, and we started straight up at 4 o'clock Mountain Time. We'll be back here every Tuesday with Fink and Friends and Fertility. So we talked about the endometrial polyp. We talked about the endometrial cavity and how we like to evaluate that. And we talked about embryo grading. Another question that I got from one of our patients was really, what is my feeling about PGT testing? So, if you're just starting the process, then you'll learn about PGT. And certainly, if you've been through it, you know what the PGT testing is. It's pre implantation genetic testing for aneuploidy. So, this is the test that we're able to do that shows us which of the embryos are normal. And if I asked you, well, would you like a normal embryo? You would say, well, duh, of course I want a normal embryo. Well, the truth is that in IVF terms, most of the time, a normal embryo is what's going to implant. An abnormal embryo, more likely than not, doesn't implant. And even though we do see folks, unfortunately, having miscarriages with IVF, and the most common reason for a miscarriage is a chromosomally abnormal embryo. Most of the time, those chromosomally abnormal embryos don't implant, and you never get a positive pregnancy test. What PGT allows you to do is to be able to test the embryos to see which ones are normal and also to be able to tell gender. So if you're doing IVF for gender selection, then you have to do PGTA because that is how we determine the gender of the embryo. If you have a large number of embryos, PGT may be useful because it's going to help to sort out which of the embryos are believed to be chromosomally normal. And those chromosomally normal embryos have the highest probability of being able to get you pregnant. A chromosomally normal embryo has about a 60% chance of giving you a positive pregnancy test. So that's a good thing to have. But if you're limited in the number of embryos, testing the embryos may not make sense, because if we have an embryo and we place it back inside of you, that embryo is going to stick. If it's normal, it may very well stick. And if it's not, it probably won't. So your body is going to give you the same information that PGT testing has done. So it's useful to take a large group of embryos and to be able to sort out using both nature and science to help you to select which of the embryos is most likely to be normal. Now, Sarah, this is a good question. What's the difference between PGTA and PGTM? PGTA is pre-implantation genetic testing for aneuploidy, and that tells us chromosomally normal. For example, it's not a Down syndrome embryo or a trisomy 13 or trisomy 18 embryo, and what the gender is. PGTM is designed to look for a certain mutation. So, for example, if you and your partner are both carriers for, say, cystic fibrosis. Cystic fibrosis is something that you can test for, and we can prevent you from transferring back an embryo that is affected with cystic fibrosis. When we're testing for that mutation, that's what PGTM is. And when they do that, they also do PGTA, so that you know you have both a chromosomally normal embryo and an embryo that's not a carrier of the disease that you and your partner are both carriers of. Let's go back to Samantha, who had a follow-up question there. It's been over a year since my HSG, scheduled for presumably a laparoscopy there in January. Well, the laparoscopy is designed to look inside the pelvis, and that's really a test that we're using, or a procedure rather, that we're using to look for endometriosis. Endometriosis is when the normal lining of the uterus that typically sloughs off when you're having a period, instead of sloughing off, works its way north inside the pelvis and can implant within the abdominal wall. And when that happens, it starts to interfere with the connection, with the communication between the brain and the uterus and the ovaries, vis-a-vis the hormones. So when that happens, it's like it's an interference in the process, and that can be a cause of recurrent implantation failure. When folks have been unsuccessful in achieving a pregnancy, we will eventually recommend either a laparoscopy or some kind of test to see if there is endometriosis. Because in the presence of endometriosis, we want to remove that endometriosis, and we can also treat that medically, which will improve the outcomes of an embryo transfer. Now, I might recommend that if you've done an HSG, the HSG test doesn't look very well at the uterine cavity. It shows us the cavity, but you have to have something that's pretty big on the inside for the HSG, the dye test, to show us that there's something there. So if you're going to be under anesthesia, Samantha, for your laparoscopy, you might consider asking your doctor to just do a hysteroscopy while you're there. Place the camera inside, take a quick look. It doesn't add anything to your recovery. It doesn't add any more pain or discomfort. It takes only another minute or two while under anesthesia. So that sounds like a reasonable thing to do here. Hey, Ryan, glad to have you. Thank you so much for your kind words there. And whoever does anesthesia, I've never actually met the person who does anesthesia here. So actually, that's Ryan, our anesthetist. So if you have the pleasure of meeting Ryan, you will see that he's a highly qualified professional who frankly is just funny looking. So I mean, but don't hold it against him. You know, he can't help what he brings to the table. Ryan, glad to have you. Oh, look at here what Jody says, and this is specifically for Ryan. Yeah, well, we love Kelly. Kelly's another one of our anesthetists here. So we're actually going to talk a little bit about the anesthesia process, and in fact, that's going to be on one of our upcoming episodes, where we'll actually probably have Ryan here in the studio, where we can talk a little bit about what the anesthesia means, what that recovery process is like, because anesthesia, I've found, is one of the things that people are often most anxious about, especially if you've never been put to sleep before. You're always worried about, am I going to wake up? And the answer is yes. This is a very safe process. Coming up this week, in fact, we are working on a behind-the-scenes video for Instagram that will show you what it's like behind the scenes at an egg retrieval, including that anesthesia process. So watch for that. That is going to drop on Friday of this week. So hopefully you'll be able to take a look. Hey, Melissa, glad to have you here. And what a sad story. We lost a baby girl with trisomy 13 and Turner's from a fresh transfer. You wish we had tested. And I'm so glad to hear that you've got that rainbow baby. That's really a wonderful, wonderful story, and so glad to hear that. Testing is it's a double-edged sword, because again, most of the time, folks who have an abnormality, the embryo doesn't implant. Sometimes it does. I'm just so happy that you have a happy ending now, Melissa. And hey, we're glad to have you with us today. Thanks for being here. Sarah says, if we're not doing genetic testing on us, then do we not need to do PGTM? That's correct. PGTM for the mutation is for a recognized genetic mutation that's in both mom and dad. So again, the example I used before was cystic fibrosis. Another, spinal muscular atrophy. To be honest, the testing that we do now, there's about 500 plus different genetic diseases that they've been able to identify the locations on the chromosomes. So it's really amazing technology, because even probably 10, 15 years ago, there were probably 3 to 5 diseases. Most of these diseases, to be honest with you, I've never even heard of. Some of them we know, again, CF is a common one, but if we find that mom is a carrier for one of these diseases, and it is a standard of care that we will offer this to you as part of your preconception testing. If mom is a carrier, then we test dad. And if dad happens to be a carrier of the same thing, it gives you a 1 in 4 chance of having an affected baby. So the time to find out about that is obviously before you get pregnant. And that's what PGTM is designed to test for. PGTA is the routine testing for aneuploidy and for gender. Well, hello there, Mrs. Bell, coming back to do another cycle. Outstanding. Oh, and here's a little comment if you didn't see it. Ryan was awesome on 10/7. That may have been one of the only days that he was awesome. So if I'm sorry, I couldn't resist. It was just too easy there. But thank you so much for all the kind words. And Melissa, hey, how are you? Thanks for being here. And I had to put this one up on the screen. The Colorado office is amazing. Well, thank you very much. You know, we try very hard here, and I really try to feel like, even though the CNY system is a big one, our colleagues in New York, they do a fantastic job, but we really try to make you feel like this is a boutique kind of place for you. When you are here in our office in Colorado and you're seeing us and we're seeing you, we want you to know that you are the most important person in our world at that moment. And that's really what we try to send you away with: the hope, the care, and the love that we have to provide CNY as a whole, but Colorado in particular. So Melissa, thank you so much for those kind words. And here's a good question. Do you ever have an embryo split during the first days after fertilization? Yes. In that case, would you PGT test both or one? Oh, I see. The time for embryo splitting happens after the embryo is already back inside the uterus. So the process for PGT requires you to grow the embryos to the blastocyst stage. And the blastocyst stage is typically day 5, sometimes day 6, and sometimes day 7. They grow to blast, and then they get biopsied. Now, here's an interesting fact. The reason that that it's not a perfect process, because remember we said with PGT testing, a euploid embryo is said to give us a 60% chance of a positive pregnancy test. Well, why not 100? If it's a chromosomally normal embryo, well, why wouldn't that embryo be the one? Why is it only 60%? And the answer to that is because it has to do with the way the testing is done. When they biopsy the embryo, what they're biopsying is a portion of the embryo that's called the trophectoderm. The trophectoderm. And what that is the portion of the embryo that will become the placenta. So it's possible to have a normal placenta and an abnormal baby. Or it's possible to have a normal placenta and an abnormal baby. And we do know that some of the abnormal embryos will correct themselves on the inside. And there are some shades of gray. There are things that are called mosaics and lots of different kinds of findings. But even the aneuploid, or the embryo that the lab has said is abnormal, still may have a 10 to 15% chance of giving you a normal baby. So the time that the embryo splits, if we place one embryo inside and you end up with twins, that's because it split once it was already inside of you. So good question there, Melissa. Thank you for that. Here's a question about sperm issues and which makes better quality embryos. What happens in some cases, if you don't know, for men who have male factor, for couples who have male factor fertility concerns, and the man is not able to ejaculate sperm, the sperm can be extracted from the male, either from the epididymis, from a portion of the testicle, or from the testicle itself. What the male fertility specialist decides to do is really dependent upon the individual male and on where the problem lies. But remember, all it takes, well, put it this way, male infertility So a normal male ejaculate may have, let's just say 35 or 50 million sperm in an ejaculate, about a teaspoon's worth of ejaculate. 50 million. Well, functional male infertility, let's say that your partner has 2 million, 2.5 million sperm in the ejaculate. The doctor's going to tell you that's male infertility, and there's going to be a problem being able to reproduce, at least at home, in a situation like that. For our concern with IVF, we say, well, how many sperm does it take to fertilize an egg? One. That's exactly right. So if there's 2.5 million sperm, that's still a heck of a lot more sperm than we actually really need to do the process. So PISA versus TISA really shouldn't make a difference as long as we have adequate numbers with motility. Thanks, Desiree, for that question. And Sarah, hi again. Let's see, what's the process for a fresh transfer? What makes you not be able to have one done? And that's a really good question after the retrieval. So the first thing I'll tell you is that the fresh transfer is included in the price here at CNY. And so as long as you're able to do it, we would recommend that you try to do it. Now, there are some situations where your body will tell us that it's just not the right choice. When for the retrieval, we have caused you to make eggs. When you are really super duper into egg making mode, then egg making mode may not be consistent with being pregnant mode. And if that's the case, then we will tell you, well, you know what, a fresh transfer is probably not the best idea. That's generally based on the estradiol level, that's your estrogen level, or the progesterone level. The estrogen tells us how much estrogen is circulating in your body. And when it gets high, it's associated with ovarian hyperstimulation or excess egg making mode. And the progesterone part tells us about the window of implantation in the uterus. When that number gets too high, it oftentimes means that that window of implantation has closed. So the plan is, if you'd like to do a fresh transfer, do it, unless we tell you you can't. So that's kind of the way that goes. Hey, Amber, glad you could be here. And Desiree also, we've got Melissa there. How does the embryologist pick the very best sperm for ICSI? Well, there's a couple of different ways. This comes from Melissa asking a question about sperm and ICSI. ICSI, of course, is the process where the embryologist takes what appears to be a great sperm to place it directly inside the egg so that fertilization takes place. You may know that what they call conventional IVF is when they would just pour sperm basically onto the egg and let the sperm swim its way to the inside to get inside the egg. Sometimes that works, but if it doesn't, we're left to do a process that's called rescue ICSI. And when we do rescue ICSI, the outcomes aren't as good. So at CNY, our standard of care is to do ICSI for all embryos unless you've requested otherwise. And then what we do is place that sperm inside the egg. The embryologist is a professional, quite honestly, at looking at sperm to find which one appears to be the best. So the most normal looking, because sperm have heads and they have necks and they have tails. And so they know to look at that and to be able to look at the motility of the sperm to see how it's swimming to determine which one seems to be the best. There's also a procedure that you can do. It's an add-on that's called a Zymot. And you can read about Zymot on the internet and also on our website that tells about what the Zymot process is that helps the embryologist to select the best sperm. Now, there's not great evidence to show that Zymot makes a huge difference in outcomes because the talented embryologist should be able to pick that on their own. But Zymot is certainly an add-on we can do as well. We're going to take one more question here, and then I've got a special guest I'd like to introduce. Well, actually, one quick thing here. Sarah says, how do you know when you can do the fresh transfer? I would say plan on doing the fresh transfer unless we tell you can't, and that'll be from the last blood test that you do. Or if it looks like you have a ton of eggs. If it appears that you've got 40 follicles, for instance, I'm going to tell you you're in egg making mode and a fresh transfer may not be the best idea. But the last blood test that you do before your retrieval ought to be the one to tell us. Here is that question. And that's since my fresh transfer failed without a booster, doing boosters, will HCG boosters help? HCG boosters are when we give you a little extra of the pregnancy hormone that you do in the form of an injection. The HCG boosters function in the body as progesterone, and it's that progesterone hormone that talks to the lining of the uterus and says, continue the pregnancy. And that's why you have to do the cursed PIO shots and the vaginal progesterone. HCG boosters gives you extra progesterone. And particularly if you've done a natural cycle or a modified natural cycle, that is especially when I would recommend that you do HCG boosters. We do offer them also in medicated cycles, so certainly worth looking into there. So I would say yes, it's not going to harm anything. And thanks for that question. Hey, I do want to invite a special guest over. Joining me in the studio today is one of our wonderful, I'm going to move the mic here a little bit out of the way. Here she is. This is one of our wonderful operating room nurses. This is Loopy Thompson.
Hi.
Loopy has been with us for how long now?
A year and a half now.
A year and a half. Tell us a little bit about your background and what brought you to be able to do the kind of acute care that you see in the operating rooms here at CNY.
Okay, well, thanks, Dr. Fink. Hi to everybody out there in CNY land. I have been a nurse for going on 8 years now, and I have kind of touched a lot of bit of the areas at the hospital. I've done cardiac, I've done intensive care, and most recently I've done post-anesthesia care, which has brought me to Fertility, which is pretty, I'm not sure there's a whole lot of nurses out there who have background in fertility. So it was pretty new to me, but fortunately coming on with Dr. Fink and the other staff here, it was pretty seamless, and I really enjoy taking care of people, especially after anesthesia, because it seems like Dr. Fink said, that seems to be a spot where most people have a lot of anxiety. So after anesthesia,
you've worked in the ICU,
Mhm.
you've worked in the recovery room,
Mhm.
right? A lot of places where people really need that skill set.
Yeah.
I think you're absolutely right that time that you're waking up from anesthesia is the time that you really need a good caring soul there to be with you to help you through that process. There's your caring soul. Is there anything that you've learned from your time here in the recovery room and folks waking up that you'd like to share?
Oh, everybody's different, so I'll start with that. But I thoroughly enjoy taking care of patients, especially meeting everybody. We seem to get a lot of Minnesotans, a lot of Californians, not a whole lot of Coloradans, surprisingly, but we would love to see so many more Coloradans. I really enjoy hearing people's stories and what's brought you to come to CNY, especially CNY Colorado. It's really just our pleasure to help people continue to make families or to start their family. So
now here's a very important question that comes from Melissa, and I'm going to put it up here so that you can see it.
no, it's not Lupe. It is Loopy. Dr. Fink did say it correctly, but that's a question I do get a lot. So thanks for asking, because yes, it is Loopy.
Her real name is Guadalupe,
Mhm.
and her sister's name is
Pamela and Angela.
Pamela, Angela,
Mhm.
and Guadalupe.
Hi.
Yes, thank you, Jody. She wakes you up, and she wakes you up when you're loopy. And
Yeah,
so
and that is one of my jokes. I do love to say, "Hi, my name's Loopy. It's not just the way you feel." But yeah, in general, though, I will say to Ryan's, the way Ryan does anesthesia, you wake up feeling like $1 million. So yes, you may come in feeling a little bit icky because like Dr. Fink said, your ovaries are in egg making mode, but with Ryan and Kelly's and Art's anesthesia, and you wake up feeling like $1 million and like you just took a really nice nap.
Well, you would agree that people are naturally anxious about
Absolutely.
getting anesthesia. How does the
Absolutely.
anesthesia that we have here differ from what somebody might have if they were at the hospital having a major surgery done?
Oh, I mean, Ryan, Kelly, and Art can testify to it's night and day. The anesthesia here is MAC anesthesia. It's just through an IV, and thanks to their skill set and the way they give you medications and the order they give you medications, you do wake up feeling. Most of our patients are not nauseous anymore. They're not anxious anymore. Their pain is controlled, and they of course got the hydration from the fluids that we give you. So you do feel just much better than in a hospital setting. And the nice thing about our clinic is, you see us looking like this. We're in normal clothes. We're, wearing earrings that you don't see in the hospital. It's not as calculated as it is in the hospital.
Well, the other thing is that our procedure takes 10 minutes maybe, as opposed to most of the kinds of things that you might have in a hospital setting are major anesthetic because you're looking at much bigger, much larger procedures. So in something that's so quick for us here, we like to keep you comfortable, but not so much that you feel it all day long. Most people would go home and take a nap.
And most people eat normally after they leave. They drink water. CNY is very generous, and we give you little snacks and juice to make you feel better before you leave. That little rush of sugar just hits differently after anesthesia. And truly, patients leave feeling better after their retrieval, thanks to Dr. Fink and Brandis' skill set also.
Luby, can you explain the difference between what they call twilight versus regular?
I can't specifically speak to that because I'm not an anesthesiologist, but I will say it's my understanding that the twilight is when you start to go under, and I think it's the conscious sedation part of it when they push the versed, and the regular and twilight for the, what is?
Well, so typically what happens is that in twilight, they're giving you something that you may be sort of sleepy, but you're still pretty aware of what's going on. In our situation, we give you sedation through the vein so that you're asleep comfortably. You're breathing just regular oxygen. There's no inhalation anesthesia there. So it's really just through the vein, and you don't have to see it, smell it, participate in it, or be a part of it at all. Just take the best nap you've had in a long time, and nobody can bother you while you're sleeping. So that's kind of a nice thing there. Really, the one more question, Luby, I would ask you about is the other thing is that people are often concerned about nausea. Anesthesia sometimes causes nausea, but what do you guys do to help people feel normal and not be nauseated after procedure?
Well, again, that's thanks to your beautiful anesthesiologist, Art, Kelly, and Ryan. They give you a medication called Zofran. It's an antiemetic. The nice thing about Zofran is they do give that to you as you're going under, but you are able to tolerate 2 doses. So if need be, the nurses can give you an additional dose. And we also have some other cocktails that we're able to give you if need be. But again, the anesthesia is so nice to your body. Most patients don't feel those things. So.
Well, that looks like it's going to be about all the time that we have for today. Joining me here, this is Jody, who is our nurse manager at CNY Colorado. This is Brandis Montez, who is our nurse practitioner. Thank you guys for being here. You'll see these folks again as we continue this series on Tuesday afternoons at 4 o'clock Mountain Time, 6 o'clock Eastern. Fertility with Fink and Friends. We're so glad, CNY Nation, you were able to be with us. Our hopes and dreams are you and are with you.
Thanks for joining.
Thanks so much for being
Bye.
here.
Good night.
Have a great evening.
Thanks, Nate.